Okay, we're going to cover the portion of lecture that we didn't get through the other day. This is chapter 26, Care of the Patient with Burns, and I've sectioned out just these slides that we need to go. So remember that I mentioned that your biggest issue with a burn is going to be a loss of fluid and electrolyte homeostasis. So fluid shift with movement or loss of different types of electrolytes that could be in higher or lower values than what they're supposed to be that could cause some significant issues. So when we're talking about burns, it's anything from a sunburn to a major full thickness burn, and we're going to talk through those. Treatment can last months if it's a significant burn, and there can be lasting damage, especially related to contracture and different things that could develop as scar tissue takes place. So our primary issues as far as the pathophysiology of burn injury goes is that, again, it's that effect that it has on the fluid and electrolyte balance. There is a protein loss as the vascular system opens up and allows those large proteins to leave the vascular area and to move out into the cellular area, into the third spacing. It takes with it fluid then, because we're always going to try to maintain an equal solution, solute balance. So fluid will follow the large proteins out into the third spacing at the injury site, and that's the cause of edema to the area. If we're talking about a significant burn, the problem is that that's going to happen on large scale, causing significant hypotension as we have a lot of fluid leave the vascular space. And we'll talk through that later again. Another big issue is sepsis. We can have shock that occurs that is hypovolemic shock, as I mentioned, as we develop hypotension when all that fluid leaves the vascular space. But then our second biggest concern is with infection. If we get past the initial very dangerous time of the initial burn, then we're concerned about later developing infection as long as we have those open wounds. Any kind of infection can lead to sepsis, which can be life-threatening. Late complications I've mentioned already is contractures and scarring. So we'll talk about what could happen there and how to prevent those changes from impacting function. The depth of burn injury is a big determinant in the severity, in recovery, and overall survivability of the burn. So we determine how much body surface was involved, as well as the depth of the burn into the layers of the skin. So both of those factors are important in determining just how severe the burn is. Also consider that our skin is different thicknesses over different parts of our body. So a burn to the torso where there may be, extra dermis layers, extra adipose tissue, is going to be different than a burn, say, to the face or to the hand where we have much thinner layers or less thickness. And so automatically a burn in one of those thinner areas is going to have a greater severity simply because it becomes a full thickness burn much more easily. So those thin areas to kind of keep in mind as being more severe if they're burned are the eyelids, ears, nose, the genitalia, tops of hands and feet, fingers and toes, which are common burn sites. Also remember that there's some considerations for older adults. With natural processes of aging, we have thinner skin, more at risk for deep burns, simply because of that thinner layers. Even though temperature and time exposure may be reduced as compared to other types of burn in younger individuals, is going to produce a more severe burn in that older adult skin. So burns are going to be classified as superficial thickness, partial thickness, and there is a superficial partial thickness and a deep partial thickness, two subcategories. And then the next category is deep, full thickness wounds. Then we say that burns are classified as minor, moderate, or major. And that's a combination term that considers the body surface as well as the depth. This kind of gives you an indicator of the superficial partial thickness, a deep partial thickness, and a full thickness. So these are significant burns. It's not a superficial. The superficial partial thickness has a more of a pinkish color, whereas the deep partial thickness has a more reddened color. Now we've gone down deeper into the dermis where we're involving more of those smaller vessels, and that's where you get that more red, I'm going to say petechiae looking color. Now the full thickness burn has like a white appearance, and there's a brownish circle just off of the arrow there. So this is described as a leathery appearance. So we've burned through multiple layers. And so that's a key term for you to remember with determining full thickness, is that it has a leathery appearance. This is a picture from your book that kind of just gives you an idea of what this means depth-wise. So superficial or first degree is just in that epidermis part. So they can be very, very painful because we're still right there in all of those nerve endings. So it doesn't mean that the pain is less by any means, but it doesn't have the depth. So it's going to heal much more quickly, less risk for infection, less risk for contracture development. So, we can even have sunburns that are the superficial first degree and even into second degree, actually. This would be the type of burn that you might get burning your hand on the stove or something like that. A partial thickness then goes deeper below the epidermis into the dermal layer. So we're still in those nerve endings, significant pain. You're probably really going to see a lot of blistering with the partial thickness, especially if we have a more deep partial thickness burn. The full thickness then goes completely through the epidermis and dermal layer. So we're down into the subcutaneous layer. We may even see muscle. Muscle can be burned as well. And it's considered that third degree burn and is very significant and even life-threatening. Again, it develops that leathery type appearance. This talks through each one of those that I just described with the picture. So I'm going to highlight some important things that I haven't mentioned yet. With your superficial thickness, so usually heals in 3 to 6 days without scarring. You know, like those examples that I gave you, a low intensity heat like sunburn, or a flash exposure like a hot pan or something on this. The partial thickness then is going to heal in 10 to 21 days. There could be minor pigment changes to that area of skin where the burn was, so it may heal a little bit lighter than the original color of the skin, and some of that is the collagen formation. And then with your deep partial thickness, it's going to take a little bit longer, up to maybe 6 weeks. So instead of just under a month, it may be a month and a half to heal those because it's a little bit deeper than what the superficial is. You would definitely expect to see some scar tissue related to the deep partial thickness injury. With the full thickness burn, then remember that we've gone entirely through the epidermal and dermal layers, so we don't have any skin cells to regrow. We'll talk about grafting and different things that we can do to reintroduce cells to that area and allow new tissue growth. Now, after the burn, there is going to be a hard, dry, leathery eschar that forms in that area. It can be a waxy white or even a deep red to black in color. A lot of times that has to be removed before healing can begin, before we can do grafting, anything like that. Your full thickness burns are also the ones that are the greatest risk for creating compartment syndrome. Now, anytime we have swelling and edema, we can have compartment syndrome that occurs because we have so much fluid in that area that the skin can no longer stretch any longer, and it becomes a tourniquet to the extremity, especially. With the full thickness burn, just the inflexible nature of that hard, dry, leathery eschar can also create that tourniquet-like or compression-like issue on a limb or even around the trunk, which makes it difficult to breathe. They may have to do an escharotomy, which is an incision through that eschar to break it up and allow for flexibility, but they may have to perform a fasciotomy as well, where they do an incision through the eschar and the fascia to allow expansion there. So it's a therapeutic surgical incision that they're doing to allow either for blood flow or for breathing. Another thing worth mentioning, the full thickness burns, especially very severe, may result in amputation. There isn't always the possibility of doing excision and grafting, especially if there's been extensive damage to the tissue, to the circulation, nerves, even bone can be burnt if it's deep enough. So that is a possibility. This is an example of what the escharotomy with a fasciotomy would look like to open up and allow for stretching of that skin so it doesn't tighten and block circulation to that limb. Different types of burns can cause different results. Some possible would be like a dry heat burn. So it's like an open flame, a house fire, falling in a campfire, something like that. A moist heat or a scalding burn is anything from a hot liquid being spilled onto the skin or body, or a steam burn, which can happen because steam is especially hot. Immersion burns are moist heat. A lot of times that happens with babies accidentally if we don't check the bath water before setting them down in it. Contact would be a very hot material getting on the skin and then sitting like a hot metal, tar, or grease. Chemical is contact or ingestion of a chemical agent that causes corrosion and burning of the skin. Make sure with a chemical type burn that you understand what type of chemical that the patient has been introduced to, because you don't always want to flush with water. Some chemicals can be further activated with water, and so you'll want to respond appropriately based on the chemical that they came in contact with. With an electrical burn, we're talking about electrical current that burns the body. They typically look small on the surface, like a singular burn mark of entry and exit, but internal injury can be very, very significant. And then radiation burns depend on the severity of the type of radiation. There's different ways that radiation is delivered, even therapeutically for cancer treatment, distance from source, duration of exposure, that type of thing. So those burns, like I said, even for the treatment of cancer, can be significant and require treatment as well. Of course, before we get into the meat of things, of really talking about how to treat different types of burns, it's always important to educate patients about burn prevention. Always assess water temp before bathing or showering or immersing, and especially if you're putting a baby or even adult who is unable, nonverbal or unable to tell you that the water's hot, if they're debilitated in any way, they recommend you use your wrist or your elbow. Sometimes the hand can be a little bit desensitized to high temperatures, but more sensitive at the wrist or elbow for testing that water. It's going to give you better accuracy for the sensitive parts of the body. Use pot holders, obviously, with pans. Don't add flammable substances to open flames. So people shouldn't be starting with fires with gasoline and things like that. Wear sunscreen and protective clothing. Again, sunburn can be a pretty significant burn, up to second degree, with blistering and all kinds of horrible things. Don't smoke in bed. Don't smoke while drinking alcohol or taking any sleep aids. If somebody, states that they, wake up in the night and have a cigarette or something like that, there's always the possibility of them falling asleep and it catching the bedding on fire. And then obviously, if they're under the influence of anything, there's the chance that um, that could again start a fire. I'll add to that too, not smoking or while having oxygen on. Keep matches and lighters away from children. Keep clothing, bedding, anything away from a space heater that might be in use. Chimneys are to be cleaned yearly. Keeping grates closed. Have a smoke detector in each room and change the battery regularly. Usually people are encouraged to change their smoke detector batteries every time the time changes. So twice a year in spring and fall, just going ahead and changing those out or having them hardwired into the house if that's a possibility. Okay, when burn injury occurs, we're going to go through changes as they relate to each system. It's easier to break it down that way. So we've already talked about some of the vascular changes. So our initial response to any kind of injury is vasoconstriction with loss of circulation. This is to prevent bleeding. The same thing happens with a burn, even though there may or may not be bleeding associated with it. And this can cause additional damage because we're vasoconstricting an area that needs some circulation. Next is the fluid shift situation I was talking about. The blood vessels near the burn will dilate, open up, they'll leak out those big, large proteins and the fluids then into the interstitial space. This is known as capillary leak syndrome. And we can see that hallmark third spacing where we get all of that edema in that area. Again, if it's substantial enough, this impacts our overall blood volume. So we have a decrease in our vascular system where we have a plummeting blood pressure. The patient is actually going to experience extensive weight gain in the first 12 hours after the burn. The body is losing fluid out of the vascular system, so it quits allowing fluid to leave through the urinary system. So we begin retaining all of our fluid to try to maintain our blood pressure. Aldosterone is signaled to keep salt in the kidneys, and so every bit of fluid that we have will stay, so we'll just keep gaining weight essentially. There are electrolyte imbalances that occur right away. All of the cells that are damaged are lysed and they release all the potassium that they were holding. And then we have hyponatremia because the sodium is going to follow where all that water is going. So it's leaving the vascular area or the serum levels and it's going out into the third space along with all of our fluids. So with low sodium, remember all those signs and symptoms with confusion and spasms, risk of seizure. With hyperkalemia, of course, our biggest issue then, we're very concerned about possible cardiac dysrhythmia, maybe even myocardial infarction as a result. There's a hemoconcentration because we have more fluid leaving the vascular space than we do have of the solute or solid materials. So we immediately have a higher osmolality. Our hemoglobin and hematocrit are going to be higher. We'll have a tissue hypoxia issue because we're no longer transporting oxygen efficiently, even though our hemoglobin and hematocrit are up. The loss of the plasma volume is significant as far as getting oxygen to the tissues, and then the area where the burn is, there's a lot of edema, so there's not great oxygen exchange occurring there at all. This is a visual that kind of shows that capillary leak syndrome, and it mentions again our issues that go along with this occurring. The one thing that I haven't mentioned yet is the metabolic acidosis. So if you recall, when we have an issue with all of that potassium leaving the cells, the other thing that is leaving is the hydrogen. So with our increased hydrogen, we end up in an acidotic state. The kidneys are not in a position to be able to buffer that very well, and their response is going to be slow anyway. Just remember, acidosis goes along with this initial state as well. And then, of course, the next obvious area that we need to consider for assessment is the skin. Again, it's the size and depth of the injury, aka the total body surface area affected, and then how deep into the skin layers the burn goes. It's important to get this calculated because it's going to be the basis for how we give our drugs, how we rehydrate or increase the fluid volume, and how we determine what the caloric needs of the patient is going to be. We're going to focus on the rule of nines because it's the most simple. There are other methods that are definitely more accurate, and they will be used if you go to work in a burn setting. But for what we need to accomplish here, the rule of nines just divides the body up using 9% as the basis for calculation, and it's actually really pretty effective. You can apply rule of nines to some of the other methods, and you're not going to be very far off. So this is especially helpful in the field for calculation and on immediate arrival before you take the time to do a more accurate calculation. No matter what method you use, all are going to express the burn in a total percentage of total body surface area. So even using the rule of nines, when you add up all those numbers, it means a percent of the body surface area. So if you get 40%, it's a 40% burn. This picture kind of shows how the rule of nines is divided. So the head is given 9%, and it's divided into 4.5 for anterior and 4.5 for the posterior. The torso is double, so we work with 18% for anterior and 18% for posterior. Each of our arms is given 9%. So we've got 4.5 for anterior, 4.5 for posterior. Our legs are again given a 9% anterior, 9% posterior, so 18 in total. And the genital area is another 9%. Cardiac changes that occur initially is the heart rate is going to increase and cardiac output decreases because we've had that capillary leak and a fluid shift. So the heart is going to pump faster because there's less volume to circulate, but our cardiac output is going to go down for the same reason. So even though the heart is working harder, there's just less fluid to circulate, and so you could have a low cardiac output for 18 to 36 hours, even as we're trying to rehydrate. Our biggest concern is for hypovolemic shock. It's a common cause of death in the early phase because of the fluid shift, all the fluid leaving the vascular space. You'll see a lower and lower blood pressure, and we'd be very concerned that the patient could succumb to hypovolemic shock in that situation. You want to make sure that you start fluid rehydration immediately, and the patient will be put on medications like pressors that help to keep their blood pressure adequate for perfusion of major organs. Vital signs are critical to determine if blood pressure and pulse are changing, and if possible, we need to be monitoring the cardiac rhythm. This is especially true for electrical burn injuries, for electrical shock, because the potential for it to have caused a dysrhythmia in itself, let alone the potassium changes that it could be occurring because of the burn. Respiratory assessment is especially important. It sometimes gets forgotten because it's not visible injury. It's very possible that during a burning injury, there's also been a burn to the respiratory tract. If the patient has burns to lips, face, ears, neck, eyelids, eyebrows, eyelashes, then that's a strong indicator that there could have been an inhalation injury. One way to really tell is if there's black particles in the nose, if the mouth is black, if the sputum that they're coughing up is dark in color, and they may have a smoky smell to their breath because they've breathed in uh, that that smoke from the fire. Most patients are going to be intubated immediately if we suspect respiratory injury. We won't allow them to go into respiratory distress. However, if they do go into respiratory distress, the first thing that you need to do is assess for an airway. And if they have an open airway, we need to provide oxygenation. But where they're heading is intubation. That's going to be the treatment for respiratory injury. So, the signs and symptoms of pulmonary injury that you want to be especially aware of, and you want to make sure you remember these. The patient is going to become progressively more hoarse. They may be hoarse to begin with, but their voices become more and more gravelly. They're going to have a brassy, nagging cough, continuous cough. They may drool or have difficulty swallowing. This could be because of restricted airway. So that's going to be a sign that we're headed for a bad situation. Like I said, maintaining airway is the priority. They may produce sounds on exhalation that are wheezing, crowing, or a stridor. We know that stridor is a medical emergency and it would indicate intubation immediately. If somebody has been wheezing or had stridor and now they have no expiratory breath sounds, that typically doesn't just fix itself right away. Instead, you would be very concerned that you've lost your airway and you would need to act immediately. So if they're still coughing and wheezing, you can establish that there is an open airway, we're going to give oxygen. Make sure you continue to monitor their pulse oximetry. But if that wheezing, if their breath sounds become absent, we need to establish an airway immediately. And don't forget, if we know that there's a possibility of respiratory injury, intubation is usually done proactively. Um, Table 26-3 on 490 goes over indications that there is injury to the respiratory system. There's some things that weren't covered on the previous slide. So, patients who were unconscious at the time of injury, if, let's see, they're using accessory muscles or stridor, we talked about. So read through those. There is a critical rescue that I'd like you to notice. It says monitor patients' respiratory efforts closely to recognize possible airway involvement. Just like tissues of the skin and everything else get edema, so do the tissues within the respiratory tract, and they can close off, and they can also have mechanical injury that cause blockage of the airway. For a burn patient in the resuscitation phase who is hoarse, has a brassy cough, drools, or has difficulty swallowing or produces an audible breath sound on exhalation, respond by immediately applying oxygen and notifying the rapid response team. So recognize for a bad situation. Injury to the respiratory system includes direct airway injury, which is rare. Typically, we don't have actual burning of the tissue in the airway, unless it's related to like a chemical inhalation or something like that. Typical causes, though, can be superheated air, so just very, very hot air or steam coming from something that's burning. It could also be from toxic fumes, so that's like the chemical burning. And then smoke can cause respiratory damage. Carbon monoxide poisoning, we're going to go over. It could be thermal injury, which is that basically superheated air or steam. Smoke poisoning goes back to that toxic fumes. We could have pulmonary fluid overload. Maybe we don't even have an injury to the respiratory system, but because of fluid shifts that occur related to burns elsewhere in the body, especially if they're systemic, we certainly could see pulmonary fluid overload and go into pulmonary edema. Remember, one of the signs of pulmonary edema is pink frothy sputum. External factors could impact the respiratory system, like we talked about the restriction that especially deep burns may cause, or edema to the trunk, anything that doesn't allow for adequate lung expansion, and then facial edema because the burns can close off the airway. Carbon monoxide poisoning is one of the leading causes of death from a fire, and it can kind of be forgotten. There's a couple of reasons why. So, if you have somebody that's burned badly, of course, that's a visible and can be traumatic thing. So we always have to think about what could have been inhaled. So if they inhaled a lot of carbon monoxide, they could have carbon monoxide poisoning. The thing about it is carbon monoxide binds very tightly to hemoglobin in place of oxygen. In fact, there's an affinity to it. So the PaO2, or the partial pressure of the oxygen, will remain basically normal because carbon dioxide decreases oxygen carrying capacity of the hemoglobin, but it doesn't impact the arterial ratio of the oxygen partial pressure. So in other words, your pulse ox is going to lie to you. If you do ABGs, it's going to lie to you because oxygen saturation might be decreased a little bit, but not significantly. But all the while, they have a very high uh, um, uh, um, uh, I'm sorry, my mind just went blank. They have a very high carboxyhemoglobin. I'm sorry about that. They'll have a very high carboxyhemoglobin level. So that's what you actually need to check to determine if there is carbon monoxide poisoning. The second thing is there's going to be extreme vasodilation that causes a really cherry red color of carbon monoxide poisoning. So you're not going to see any evidence of cyanosis. So you're not going to notice that tissues are not being perfused. You're not going to see blue lips, those typical things that are going to cue you in on a respiratory disorder. The cherry red coloring of the skin will occur as the carbon monoxide becomes more advanced. Unfortunately, it's especially visible post-mortem. So if we get to that point, unfortunately, like this picture here is actually of a deceased individual that died of carbon monoxide poisoning. So when you see that cherry red coloring, it means that the carbon dioxide poisoning is very advanced, and so you need to respond right away. But the best thing that we can do is check that carboxyhemoglobin level. So definitely remember that ABGs are not going to do you any good. Neither is your pulse oximeter. Other things that you can notice about, less extreme carbon monoxide poisoning or exposure is symptoms that the patient might display. Definitely complaining of a headache, especially if they've been exposed to it chronically over time. So people that have like heaters that are working ineffectively in releasing carbon monoxide into the home. A lot of time people will complain about being disoriented or having a headache or dizziness over a period of days. It's going to impair the cerebral function, causing that confusion, and they can also go into a coma as it becomes more significant. They're going to complain of muscle weakness and cramps, and they could potentially have a seizure. They're going to have aggravation of heart and respiratory diseases. I mean, if they already have COPD or some other issue, they're going to be much more sensitive and respond much more negatively quickly to carbon monoxide poisoning. I already pointed this out to you before, but FYI, this is why your meat is red in the grocery store. Carbon monoxide treatment, they gas it and they wrap it. And so that's, it's more appetizing to see that nice fresh red meat, but it's been gassed with a chemical. So. We already touched on pulmonary fluid overloaded, so remember, even when lung tissues haven't been damaged directly, this is a concern. Histamines and other inflammatory processes with that capillary leak essentially puts the patient into congestive heart failure. This can lead to edema and obstruction of the trachea. Recognize the biggest risk for this is about 8 to 12 hours after the beginning of fluid resuscitation. So we begin doing our fluid resuscitation based on our calculations of percentage of burn And then as fluid begins shifting, we have to make sure that the fluid moving back into the vascular space can be dealt with appropriately through the heart and lungs, so that we don't have edema, we don't have congestive heart failure. Now, somebody who has pre-existing condition, obviously this is going to make this a much more complex case if they already have CHF, and we need to be very careful with this fluid resuscitation. What you need to make sure that you do is keep the head of the bed up at least 45 degrees, going to help them breathe more easily. You need to apply oxygen, and you need to notify RRT or the rapid response team immediately. We also have gastrointestinal changes that happen because of burns. There is an immediate shunting of blood from the GI tract. That's part of the sympathetic nervous system or the fight or flight response. We're going to make sure with all those vascular changes and the depletion of the plasma volume that we're perfusing those organs that are most necessary. And so the GI tract gets shut down right away. There's there's those increased secretions of epinephrine and norepinephrine that cause this response. So there can be an infarction because there is a reduced blood flow. So we could actually have death to part of the bowel if there is interruption of circulation for long enough. It's very, very common for people that have burns, especially extensive burns, to develop what's called a Cushing's ulcer. It's a stress ulcer that develops within 24 hours of a severe burn injury because there's decreased blood flow to the stomach and decreased mucosal production, which provides protection. So the hydrochloric acid of the stomach begins to burn the lining. All burn patients are going to be put on an H2 blocker, the histamine blocker, or a PPI, proton pump inhibitor, ASAP to prevent this from happening. Patients that have greater than a 25% TBSA usually will require an NG tube to prevent aspiration and remove GI secretions. So we'll have to suction them out. This also could lead to alkalosis if we have them on GI suction for too long and remove too much of that acid, that hydrogen. So keep that in mind over time. Metabolic changes that occur. Well, we get the secretion of the catecholamines that we just talked about, epinephrine and norepinephrine. We have the release of ADH or antidiuretic hormone, in addition to aldosterone, keeps fluid on board because we're losing it into the interstitial space. There is a rapid metabolism of glucose and calories, and then an immediate need for increased calories and oxygen, and that's sustained through the whole first phase of burn recovery. So we need to immediately be supplying the cells with additional calories, and we're going to try to oxygenate or over oxygenate as much as possible. There is activation of the stress response, like I mentioned. So we begin burning proteins and fats, especially if we run out of a good carbohydrate or caloric supply. We have increased nitrogen loss in the urine. We start spilling nitrogen. We have increase in core body temperature. That is expected. What I do want you to remember is that the calorie need may double or triple depending on the extent of a burn, and that peaks 4 to 12 days out. So we need to be planning for that and ensure that there's adequate caloric supply, adequate glucose supply for normal cellular function and for healing. The kidney and urinary changes that occur are typically related to cellular debris. We had a lot of damage to a bunch of cells. It's going to release wastes into circulation, and we have a decreased kidney blood flow with blood shunting. So that immediately sets us up for a possibility for acute kidney failure. We see myoglobins released from any damaged muscle, and that's additional cellular debris that may end up at the kidney, causing acute kidney dysfunction. We need to be monitoring BUN, creatinine, and sodium levels. We need to make sure that we monitor urine color, odor, presence of any particles. Urine output, again, will decrease in the first 24 hours. And so our aim, and you should probably highlight this, it should be bolded, our aim at fluid resuscitation, we're going to titrate that to maintain output of 30 to 50 milliliters an hour. So if we're not getting at least that 30 an hour out, which is the minimum that we would expect out for normal flow, we need to increase our fluid resuscitation. Once we begin seeing more and more of that output, then we can decrease it again, depending on our formula for total body surface area burned. So in the early phase, or this resuscitation phase that we've mentioned several times now, there is the capillary leak that occurs for 24 to 48 hours. uh, that's where we see hyponatremia. We see hyperkalemia initially, okay, and then we move into the diuretic stage. So I want to clarify. After capillary leak, 24 to 48 hours, we'll move into a diuresis, and so we'll see increase of fluid output. This is where our urinary output is going to increase, and we need to decrease our fluid resuscitation in order to prevent that possible pulmonary overload. Okay. Um, Potassium is going to begin to move back into the cells as we have the diuretic stage occur. We'll also begin to lose potassium through our urinary tract as we begin putting out more urine. So our big concern then is a shift to hypokalemia. We're still concerned about cardiac dysrhythmia related to that, so we'll be monitoring potassium through both phases. Hypoxia can occur because of dilution. If the hematocrit drops below 20 to 25%, we may actually have to transfuse the patient. So again, the fluid is shifting back the other direction, moving into the vascular space, and we're trying to diurese it through the kidneys, but we could have dilution and hypoxia as a result. Metabolic acidosis remains the issue. Okay, so in the initial capillary leak phase for 24 to 48 hours, we're concerned about it. But even through the diuretic stage, we're continuing to lose bicarbonate in the urine, and so metabolic acidosis remains our main concern. We need to make sure that we have an airway, that we're supporting circulation through fluid replacement, but we're not fluid overloading. It's very, very vital to keep the patient comfortable from the very beginning. We're going to use narcotics to accomplish that, and we're going to prevent infection. We'll talk about that. We're going to maintain their body temperature. It's normal for it to be slightly elevated core temperature, and then provide emotional support, both to the patient if they're aware, but even if they are not conscious at the moment, emotional support for family members. It would be a good idea to check out the labs for the resuscitation phase on page 493 and kind of have an understanding of these and understand why we have elevated or decreased amounts. Take note that the bottom two labs, your total protein and albumin, are going to be low because of loss through the wound. So having good protein sources immediately are going to be important for wound healing. Just above that is the carboxyhemoglobin reading. So we never want that greater than 10, and if it's over 20%, it's considered a critical reading. So this would be important if we were concerned about carbon monoxide poisoning. Once again, your PaO2, it may only be slightly decreased in that situation. So your oxygenation is not going to be the telling factor if it's a carbon monoxide. So management of burns is what we're going to talk about next. So our non-surgical management goes back to airway maintenance and monitoring. We want to make sure we promote ventilation and oxygenation. We'll humidify our oxygen source because we know that we could have smoke injury. We want to make sure we're giving moistened oxygenation through the respiratory tract. IV fluids are going to be given according to the response. So we'll be monitoring very closely the INO. Remember, if it falls below the 30 to 50 mil range, will increase our hydration or we will decrease. The Parkland formula is probably the most widely accepted. What I said was that more specific formula that's used like in burn ICUs and things like that. So it calculates fluid replacement as 4 milliliters per kilogram uh, times also per the percentage of total body surface area, and then that's how we give that crystalloid solution at that rate. So don't forget hydration based on the total body surface area burned as well as the output. Drug therapy is very important. We will be administering narcotics for pain control. We're probably not giving anything orally. We were mostly IV, probably morphine, Dilaudid, something like that, that works very quickly. If they have extensive burns, we may have to administer the medication. If we can't give it IV, if we're not even able to give an IM, there's different ways that we can do narcotic pain control, including intrathecal or even intraosseous. But most of the time we'll be looking at IV therapy if we have a place that we can give that. This is a picture of an escharotomy where they've just, like I said, this is a full thickness burn because you can see that waxy white leather appearance. It almost doesn't look as bad as some of the superficial areas, but it has created inflexibility on that chest, and so they've gone in and they've just cut through that top layer of skin to allow for expansion. The fasciotomy then goes through that as well as deeper layers of skin to really allow for expansion within that limb. Otherwise, we develop compartment syndrome and we lose circulation and we lose the limb. All right, so our phases of burn injury. The acute phase begins about 36 to 48 hours after the injury and lasts until the wound is closed. Okay, so we are initially in the resuscitation phase that we've defined in depth. So this is more of your diuretic phase that starts at about that 36 to 48 hour um, point. And then it's important to recognize the acute phase lasts until the wound is closed. I'm emphasizing that because we can have continued issues of the cardiovascular system, of the respiratory system during this entire time, as well as making sure we don't develop GI ulceration. Our nutritional needs are tripled or quadrupled. We need that many more calories. We also need high protein meals. We need adequate glucose to support cellular function. We're doing wound care, and we're especially concerned about preventing infection. Pain control is huge. The patient may be kept in a medically induced coma if the pain is significant. And then there's the psychosocial interventions about interacting with that patient or with family members that are very when a burn has occurred. Again, PO is not going to absorb appropriately, not going to be using that, but we can use anesthetics like ketamine or even nitrous oxide gas. I hadn't mentioned that. If we don't have adequate skin surface or vessels to do IV, IM, sub-Q, a PCA pump would be totally appropriate for a burn victim. So remember, those can be done IV or sub-Q, and they'll be either morphine or Dilaudid in the PCA. It can be set for a basal dose that is delivered continuously with doses on demand as well. If the patient is in an induced type coma where they're not able to control the PCA pump, then it's probably just going to be set for a basal dose that gives them continuous opioid pain control. We also need to make sure we remember our alternative methods. They are especially important with people that are dealing with significant pain and sometimes get discarded or forgotten, but they can be very helpful in addition to administering pain medication. Don't forget these guys. Relaxation, meditation, guided imagery, go to your happy place. Music therapy is used in a lot of different burn units. The environment is kept very low key, not a lot of loud, abrupt noises going on. Uh, Tactile stimulation is important. We still need to change positions every 2 hours, especially damaged skin, and any skin we know is at risk for development of pressure related damage. You can massage non-burn areas to stimulate circulation, but remember, we're not going to massage any areas of pressure. Hopefully they don't get those. Make sure that the room stays warm, and that the patient doesn't become cold or begin to shiver. That's going to be especially painful for that individual. We can do mechanical debridements either with hydrotherapy or as even a scraping debridement. Obviously, we need to pre-medicate for any of these. Enzymatic debridement, just like we talked about back in the wound chapter, includes patient's own cellular enzymes, which are cleaning out the wound at all times, but we can also use things like collagenase, which that Santal we discussed. We can do surgical interventions, and with our deeper burns, it's absolutely necessitated a lot of times. We can do skin grafting with mesh autografts, which would be an autograft comes from the burn victim or from a tissue donor. So we can use donor grafting. When dressing a burn, standard wound dressing is usually a gauze over a topical agent, typically never using just dry gauze because of its tendency to stick to the wound. It would cause ripping and tearing that would further damage it. So if there's a silver paste, like a Silvadene that we're using, we would put gauze over that, maybe an antibiotic ointment. We also have biologic dressings. So there's a homograph, which is a human skin dressing, heterograft skin from another species. So we can use porcine skin and other type of animal skins to help graft in over certain burns. We can do cultured, or I want to call this like a petri grown, petri just grown skin from other parts of the patient's body. So they could remove skin from one area and they can graft it to that burn, or they can take a skin sample from an area that rapidly multiplies and grow additional skin and then graft it on. And then there's the synthetic skin or artificial skin that can be grafted. I would look through chart 26.5 and, refresh with some of these topical drugs. I've already mentioned Silvadene cream, which is silver sulfadiazine, collagenase asantal. We talked about that in the wound chapter just before this. Um, look through some of the antibiotics that might be used. Gentamicin is commonly used, but remember, all antibiotics are especially damaging to the kidney, and gentamicin is no different. It requires peak and trough monitoring, and you want to make sure that the patient doesn't develop any kind of ringing in the ears that could indicate ototoxicity. Some of the other medications at the bottom are different types of dressings that are commonly used. Aquacel AG, the AG indicates that there's silver as a component, and Mepiplex AG. Both have natural antimicrobial properties because they contain silver. They also keep the wound moist and are padded and protective. So they're great dressings to be used on burns. And that's on page. So we've already mentioned infection prevention is a main concern, especially throughout the acute phase. I want you to make sure that you recognize the concept of auto contamination. The human body, the skin naturally has a lot of different types of microorganisms on it, including staph, even MRSA, and if the individual is colonized. So remember, there can be contamination, and it doesn't have to be infection. The problem is if you take that contamination from an area that's not infected and introduce it into a vulnerable wound bed, then you could have overgrowth, opportunistic infection occur. So it's very, very important that you recognize that you have to change your gloves between wound care on different parts of the patient's body. We don't want to take infection from one area of the body and move it around to another. If there is already infection in one wound, we wouldn't want to transfer that to another. Definitely don't do anything, ungodly like, pericare and then change a dressing. Cross contamination would certainly be very, very dangerous to this individual and could result in death. Make sure you're watching for signs and symptoms of infection. Those are the same as what we talked about in the wound chapter, as far as like purulent drainage, an exceptional amount of sloughing or anything like that. You're also going to look for increased white blood cell, increased fever. All of those things, represent possible infection. And then, as always, the best thing that we can do is wash, wash, wash our hands. In a burn ICU situation, visitors are always limited, and you need to make sure you educate patients on not coming in when they're sick and definitely washing their hands. In the last stage of healing, we're concerned. I mean, we're concerned throughout about prevention, but in the last stage of healing, the patient can develop contracture. If they aren't moving an area of the body during the healing process, a large amount of scar tissue is going to form, and it could cause permanent immobility of a limb or an area of the body. So, as soon as possible, range of motion has to be performed on all movable areas. So it's not just move your arms and legs. It's move your neck, move your arms and your legs, rotate your wrist, bend your fingers at every single joint, turn your torso, rotate your ankles, bend at the knee. I mean, every movable part of the body needs to be moved regularly in active or passive range of motion as soon as the patient can tolerate it. So this will begin right away so that we have a normal healing process and we don't have excessive scar tissue form. Contractures prevention is detailed in chart 26-6. Please make sure you read through these. I mentioned a few of them, but even I didn't say, even the shoulders, just moving the shoulders front and down, front and back and up and down is critical. You can even, place a pillow under the spine between the scapula to give a different position to the shoulders while that patient's in bed. And of course, we're always altering these positioning techniques, and then we're making sure that we don't end up with pressure issues. But as much as they can participate in active range of motion, do so. And you'll also do passive range of motion regularly with that patient. For quite a while after wound healing, compression is very helpful. After grafts heal and to help prevent contractures, as well as tight hypertrophic scarring, which cause those contractures, we're going to use different types of compression devices. They come in, as you can see, all kinds of different shapes. Some of them are kind of silly looking, and that can be frustrating and just add further to some of the issues that go along with having burn injury. But it is essential that these types of devices be worn 23 hours a day, and it may be a year or 2 years. But it makes a huge difference to healing, to preventing scar tissue. It also limits venous stasis, so it helps blood return. So we have decreased risk of clots, and we have improved circulation, which is key to the healing process. So these are pretty common. And again, it goes back to patient education and making sure they understand the importance of wearing this, and then helping them with some of the emotional or psychosocial issues that they may experience, to having to wear, especially like one of these masks or something like that. After we end the acute phase and the wound closure has occurred, we enter the rehabilitative phase. There is an emphasis on adjustment, prevention of scars and contractures. So we're still possibly wearing the compression throughout this phase, and trying to resume pre-burn activity and get back to the pre-burn things that they enjoyed, returning to work, doing those types of things. This can be very difficult most of the time. People with burns, they're going to be returning with significant disfigurement. And so they need to know they may not be able to participate in everything they did prior to the burn, especially if there's amputation involved or anything like that. And they need to know that it's normal to experience depression along with this integration back into life. And it's important that they have a familial support system, a counselor, or a healthcare provider that they can talk to about it, issues that they're experiencing while they go through this transition phase. This phase can last years or even a lifetime. Patients are going to be adjusting to permanent limitations. They're going to be experiencing new ways to do things, dealing with frustrations, dealing with feelings of isolation, and again, depression. So it helps if you identify those support systems right up front and make a plan. It's going to help the patient in the long run to be prepared to deal with these obstacles.